students and make a mean. Yes?
Yes.
So, for aggregate variable, you need individual data. Yes?
Yes.
You should have body weight of all the students and make a summary, such as mean, median, etc. So, for aggregate variable, we have individual level and we make a summary and put it, for example, in horizontal line of the ecological study graph. Okay, but what is environmental variable? Environmental variables are related to the environment. It is not related to one individual. Please think about it and make an example.
People work in the industry. The people who work in the industry.
Environmental level. Environmental variable. For example, air pollution. Air pollution is not related to you, to me, to you. All of us who live in one district, in one region, suffer from air pollution uniquely, similarly. Okay? So it is a kind of environmental variable. Or, for example, the height above the sea. The different cities have different height, okay, over the sea. Or sun exposure, or something like that. And how about global variables? This variable is related to the global policy. For example, fastening seatbelt, the policy of fastening seatbelt, putting a helmet, wearing helmet, or something like that. How can we use these variables? For example, if we want to see whether there is any association between air pollution and myocardial infarction, you can use the data of air pollution. For example, in Iran we have more than 300 cities, and we have the measure of air pollution in each city, and also we have the incidence rate of mortality from MI in each city. We can plot it together and see if there is any association between air pollution and myocardial infarction. Okay? Or you have many data in WHO, as I mentioned, regarding, for example, the incidence of cancer in each country. And also you have the data of sun exposure from the different sites. You can check if there is any association between melanoma and sun exposure, etc., etc. But it is not very accurate. Why? Because as our friend said, there are many factors that can affect the incidence of disease. But it is just for making a hypothesis. If you provide a hypothesis and describe your available data, you may design another a stronger study to find the association and prove your hypothesis or reject it. Okay? The data is easy to obtain, no follow-up or individual contact is needed. Why? Because you use pre-existing data. Here you can see per capita sugar consumption and age-adjusted prostate cancer mortality. And you can see that there is a direct association. It means that in communities capita sugar consumption, the rate of cancer mortality is higher. Okay? And there is a question here. Do the data support the hypothesis that increased sugar consumption is associated with increased prostate cancer mortality?
No, it doesn't.
Why?
Because we cannot determine, like, that the person who is consuming this has that cancer.
Mm-hmm. Could you please make additional explanation? Mm-hmm.
I cannot make it additional.
Uh-huh. Do you know the meaning of sentence that you say?
Yeah.
Uh-huh. So please speak about it.
Basically, I'm trying to say that we cannot determine that the people who are consuming this have the prostate cancer.
Mm-hmm.
You understand? We need to have other ideas that, yeah, this person who has prostate cancer is also consuming the sugar.
Mm-hmm. Is it clear?
Yeah.
Please let me show you a very interesting slide. I think it is very interesting and we can what is this? We have three populations. Population A, population B, and population C. What is the mean income in population E? $23,000. Okay? In population B, 22, and in population C, 21. And we have traffic injuries as well. We have, it is a hypothetical example. We have 1, 2, 3, 4, 5, 6, 7 individuals in each population. What is the mean income? We have reviewed. What is the traffic injuries in population A? 57%, in population B 43%, and in population C 29%. Okay? What is the association between mean income and traffic injuries? Please see the numbers.
As the mean income becomes less, the traffic injuries also become less.
Very good. It is a direct association. More income, more traffic injuries. But is it true?
No.
It is related to the community level. Yes?
Yes.
Why? Because it is mean income and it is a rate of traffic injuries that is related to the whole population. Okay?
Yes.
But please see the income at the individual level. In population A, who had accidents? The 3, the 4 that had the less income. Okay? For example, he is more affluent. He is more and he is more. Okay? But he is poor. He is poor. He is poor and he is poor. You can see that in each population, traffic injuries have been occurred among the poor population. But then you see the community level data, you can see that more money, more traffic injury. Why? Because in these communities, for example, if the communities are more prosper, okay, and then they are affluent, the number of cars are higher, and exactly the traffic injuries are happening among the population who have unsafe car. Yes?
Yes.
So, although the population A has more money,
But
the traffic injuries are happening among poor population among them. So, if you see the community level data, you think that there is a direct association between money and traffic injury. But if you go to the individual level, you can see that poor population have more traffic injury. There is an indirect association in the individual level. It is ecological fallacy. It means ecological fallacy. The meaning of ecological fallacy is, since the data in ecological study is related to the community, you cannot interpret the result in the individual level. Okay? We cannot say that if a person has more money, the chance of having traffic injury is higher. We can say that if a community has more money, the chance of having traffic injury in that community is higher. The level of interpretation is related to community. Okay? It is the meaning of
community,
ecological
fallacy.
fallacy. Yes. Okay. Please let me show you another example. Here you can see the incidence ratio per women regarding breast cancer. Okay? And per capita supply of fat categories. Okay? It is a kind of aggregate variable that I have mentioned. We had 3 types of variable: aggregate, okay, environmental, and global. Very good. Okay, it is a kind of aggregate because we had, for example, fat and calories in each individual, and after that we make a summary of that. You can see that higher supply of fat calories, higher incidence rate of breast cancer. So, using this slide, I can tell you that if a person consumes more fat, the rate of the chance of having breast cancer is higher.
Yes.
Yes?
That's wrong.
Of course.
I don't know.
But I told you that it is not true. It is ecological fallacy.
It's good. Yeah.
We can just say that if a country has more fat calories, the incidence rate of breast cancer in that country is higher. But we cannot say that if you individually,
By chance.
if you use more fat, the chance of having cancer in you would be higher. Okay, why? Because in that country, the mean consumption of fat supplies are higher. But we do not know if the persons who developed breast cancers who are exactly the people who consumes more fat or not?
Yes.
Yes?
We don't.
Because it is related to a country. Maybe somebody consume more fat and the other separate individuals are developing breast cancer. Yes?
Yes.
Based on ecologic study, we cannot interpret the results in the individual level. If I ask you in the final exam, your final exam, please be cautious. If the interpretation of the ecologic study is correct or not.
Correct.
In this example, please interpret the result of this. It is sugar consumption and it is prostate cancer mortality. Okay, Kai, am I right?
Comment.
Comment, oh sorry. Okay, comment. Okay.
It seems, according to this graph, that countries with more sugar consumption on average would have a higher level of prostate cancer mortality.
Very good. And if, could you please say the ecological fallacy interpretation of this result, of this graph?
Because eating more sugar is not linked to having prostate cancer.
No. The wrong sentence. I want to say the wrong sentence and tell us that we cannot say in this way.
Well, we can say that individuals who consume more sugar are more likely to get prostate cancer.
Very good. Very good. Is it clear?
Yes.
Yes. Okay. There is a very interesting example in the epidemiological books that is related to the relation between suicide and religion. In one study many years ago, scientists showed that there is a direct association between suicide and being Protestant. Protestant and Catholic are two branches of Christian religious, yes? And he showed that in Protestant countries, the rate of suicide is higher. And after that, he said that if a person is Protestant, the chance of having suicide is higher among the Protestant population. But after a while, it was a kind of ecological study because they plotted the countries based on their religion and the rate of suicide. Okay? But after a while, they tried to see who made a suicide among those countries. And they saw that among Protestant countries, the Catholic persons have been suicided. Why? Because they were isolated in those countries and, for example, suffering from social isolation or something like that. So, in the individual level, the Catholic, being a Catholic was a risk, but in the country level, the suicide rate was more in Protestant countries. It was an example of ecological fallacy that is a very common example in our epidemiological books. Okay. We are going to review the cross-sectional study. Do you remember the location of the order of cross-sectional studies? No? In the slide that we have categorized the studies. Descriptive.
With the last one
I cannot hear your voice. Please say a little louder.
it's a cross-sectional study between the discrimination.
Yes, here. I told you that cross-sectional study
Between
can be
descriptive and
descriptive and also analytic.
Yes.
Yes? What is cross-sectional study? Do you know? What is cross-section? It is a snapshot of time.
This
Yes?
هذا الفيديو ما ينشر.
No comparison between the two
Specific
two
time.
studies. So we get better.
Comment.
Yes.
Could you please tell us what is your opinion about cross-sectional study?
Cross-sectional studies is when we have two different studies and we try to compare data between both. Am I right? Because I don't remember.
No. Cross-sectional study. I want to design a cross-sectional study. For example, I have two questions. I want to know what is the prevalence. What was the definition of prevalence?
Having a disease.
How many people in the population?
Over the total population of that community. I want to know the prevalence of hypertension among medical students in Kish, and I want to know if there is any association between smoking and hypertension. I want to answer to these two questions. I want to develop a cross-sectional study and answer to this question. The prevalence of hypertension, the association between hypertension and smoking.
Ask the students whether they have hypertension or not.
Ask which students. Please go backward and start from the beginning.
Well, first we want to do the study for medical
You should
students.
select some students.
Yes. So
Yes?
select 20, 30 students out of the medical students of Kish. Ask them whether they have take their blood pressure, take it for a few days to get accurate results, and then ask the same students whether they smoke or not and how much. And then based on this, we can, for each student, write, for example, student A has hypertension or no, smokes or no. And then we can do a graph or a table or something.
Okay, very good. It is a type of cross-sectional study. Please assume in Tehran, we have different types of students. Medical students, engineering, for example, art students, etc., etc. And we think that the prevalence of smoking is different in those students. We want to know the prevalence of hypertension, we want to know the prevalence of hypertension among those those students. We are going to find the number of students in each department, and after that we can select some random sample from those population. Why random? Because we do not want to make a force and have a wrong result. The sample should be representative, should be random. For example, if 50% of our students are women and 50% are men. We try to make a sample in which 50% are women and 50% are men, as the same as the community. And for example, 10% are medical students, 20% are from art department, etc., etc. We try to make these distribution in our sample, and after our sampling process, we have a representative sample of a study population in Tehran University. And we invite them to participate in our study. We ask them about the smoking habits and take their blood pressure to find who are hypertensive and who are not. And after that, based on the questionnaire, we can categorize the students to smokers and to not smokers. Okay, it is a type of cross-sectional study. I mean that we do not know at the beginning of the study who are hypertensive and who are not, because we have just random selection. We are blind when we want to invite the students to participate in our study. We do not know about the disease, and we do not know who are smokers and who are not. So we do not know any information about the smoking habits. Okay, so the random sample is selected. After that, at that part that we want to describe the hypertension prevalence, it is a descriptive study. But when we are going to find association between smoking and hypertension, it is the analytical study. So, based on these two objectives, cross-sectional study can be either descriptive or analytic. Okay? Here you can see one example to find the possible relationship of increased cholesterol level, that is the exposure, to evidence of CHD, that is the outcome, the disease. Exposure and disease. We have used these two words, and we are using these two words many times, so remember these two. Exposure is the factor that we want to explain the relationship of these to the dependent variable. It is independent, but it is dependent because we want to work on the effect of this independent variable to this dependent variable. Okay? Cross-sectional study, the other name of cross-sectional study is prevalence study. If I ask you what is the best design to find the prevalence of something, we can say that it is cross-sectional study. Okay? The other name of cross-sectional study is prevalence study. So, you begin with a cross-sectional sample, as I explained, and determine exposure and disease and this at the same time. So, based on the disease or outcome, that in my example was
Heart disease.
hypertension.
Oh,
In my previous example, okay?
Yes.
It was hypertension. And what was the exposure?
Smoking.
Smoking. Okay. Based on disease, some of students had hypertension and some of them did not have. Okay? And about exposure, some of them are smokers and some of them are not. So we have a 2 by 2 table. Okay?
Yes.
A, B, C, D. Who are A?
Those who are smoking and have
Very
Hypertension.
good. And who are C?
They are
But not smoking.
Not
Smoking.
B,
They have
the smokers who
But
are
not
not hypertensive. And who are D?
none.
No smoking.
No smoking and no
Of course.
disease. Okay, so based on these 4 groups, we have different number of students. If we try to compare these 2 who are diseased and smokers, who are not diseased and not smokers, if we compare these 2 groups by these 2 groups and show the difference between them, we can say that there is association between smoking and hypertension. Okay? What is repeated survey? Repeated survey is a survey that is repeated frequently with a same method, with the same objectives. Why? Because we want to show the trends. I told you that the best design to find the prevalence of exposures, for example, prevalence of smoking, prevalence of hypertension, is cross-sectional study. So if you repeat the cross-sectional study in different points of times, you can track the difference, the changes in the prevalence of, for example, smoking in your community, the prevalence of diabetes in your community, the prevalence of hypertension in your community, etc., etc. It is the result of enhanced studies that is a very famous studies in US. It is a kind of cross-sectional studies, and you can see that the prevalence of kidney disease, the prevalence of stage 3 and 4 of kidney disease is
higher.
increasing. Is increasing in different points of time in US. For example, in this point of time, in 2000, the prevalence is almost 6%, but after a while, it is increasing and it is almost 7. Okay? So, repeated survey wants to track the changes of prevalence in a community. Okay? Okay. Here you can see that 2 by 2 table again. Sometimes we can look at the rows, sometimes we can look at the columns. What do I mean? Please?
He said, can you repeat the question?
Repeat the question.
Yes.
You put your hand on your face and you say it. Sorry. Sorry. Okay. I asked you a question regarding looking at through rows or columns. And you can see here, we can explain through rows, we can explain through columns. What do I mean? Think about it. Who are in the rows?
The disease, non-disease, and exposed.
In the rows.
So disease, But the ones who have the disease and the ones who are exposed.
Who are yellow ones? Please think about it.
I think
Yellow ones.
the yellow one about disease. Have disease are not
They are exposed.
Exposed.
They are exposed. They are smokers.
Yeah.
They are not smokers.
Yes.
For
Disease.
purpose.
The ones who have hypertension.
Hypertension.
Disease, yes. And what?
Don't
No
have.
disease, don't have hypertension. So, if you want to look at the rows, we can say the prevalence or the proportion of disease among exposed. Who are exposed? A plus B. Who are diseased? Among them, A. So, if you want to compare A divided by A plus B versus C divided by C plus D, it means that you can compare the prevalence of disease among exposed and not exposed. Okay? And how about column? Who are these? Disease. Okay? The prevalence of exposure among disease. Who are disease? A plus C. Who are exposed? Who are smokers? A. Versus B plus B, who are not diseased, and who are smoked among them? B. So, you can calculate the prevalence of disease among exposure and not exposure, and also the prevalence of exposure among disease and not disease. Why we can do this? Because at the beginning of the study, when I told you that we select a random sample, regardless of exposure and disease, we do not know who are diseased and who are not. We do not know who are smokers and who are not. So our sample is random. So we are free to interpret in both sides. Okay?
Yes.
So it is very important in cross-sectional study. You can say the prevalence of exposure and also the prevalence of disease. In a random sample that I said in students of Tehran University, finally you can say the prevalence of smoking in Tehran University is, for example, 10%. It is correct. And also you can say that the prevalence of hypertension in Tehran University students is, for example, 15%. It is also correct. You have power to say the prevalence of exposure and disease. I tell you this point repeatedly because there is a difference between cross-sectional study and the other studies in this issue. So please remember this point. And in the other design, we will tell you the difference. Okay? Why do you calculate both of them? Because at the first time, at the beginning of the study, you are blind. You do not know who are diseased and who are exposed. Okay? Based on these characteristics, you can calculate the prevalence of both exposure and outcome. Please see this 2x2 table. The exposure is using grape. The disease is rash. Okay? Who used grape? This number. Yes? Exposure positive. Who Who did not use this number? Who had rash? This number. Who did not have this number? Okay? So, if you see through rows, you can say the prevalence of rash among exposed and not exposed. Okay? What is the prevalence of rash among exposed? 95 divided by all population who ate grape. Okay? What is the prevalence of a rash among who did not expose? 8 divided by total population who did not eat. It is 90. It means that the prevalence of rash among exposed is very higher. So it is an association between using grape and having rash. Okay?
Yes.
What is the other approach? Look at the column.
They have eat grape and then eat.
They don't have.
The prevalence of
eating grapes among
eating grape
people who
among
have rash.
Rash.
person who had rash. 95 divided by
100.
103. And the prevalence of using grape among the population who did not rash. It means 88 divided by 1, 2, 3. Okay?
Yes.
Is it correct? A hypothetical example. Please see this example and answer the question.
Heart disease.
Cardio.
What is exposure?
Physical activity.
Physical.
Physical, yeah.
Less physical activity is exposure actually, yes.
Yeah.
Okay? What is the prevalence of CHD in the study population?
17 by 179.
The prevalence of CHD, who have CHD?
17 people.
17, very good,
The total population is 179.
very good. Do you agree? Yes, okay. The prevalence of CHD among physically active individuals. Who are physically active?
The row.
90.
Yes. The prevalence of CHD? 7. The prevalence of CHD among physically inactive individuals?
Of 189.
10 by 89.
It is simple. Okay? What is the prevalence of good physical activity in CHD patients? Go through columns.
7 divided by 17.
7
divided by
17.
17.
Very good. And what is the prevalence of good physical activity in non-CHD persons?
83 of 162.
Very good. Okay. So, when we want to do a cross-sectional study and try to select our study population, regardless of information about exposure and outcome. And we selected some students and asked them about the history of smoking and also hypertension. Can we say that smoking is a risk factor of hypertension?
Yes.
Yes?
Yes.
Why?
Because the most of that have smoking have a chance to get disease, hypertension.
I asked you a question. In this random sample, I have some disease and have some healthy population. And I asked them about the history of the smoking. They tell me that, for example, I smoked from 1 year ago or 2 years ago. But they don't know the exact time of having hypertension. Can you say that smoking becomes before hypertension?
Maybe.
Maybe, but maybe not.
Maybe.
So, I told you in the previous session that risk factor defines a factor that becomes before disease. Please consider, please assume the situation in which we see a broken window with a stone under the window. We think that, okay, the stone probably is the cause of breaking the window. But we cannot say this with certain. Yes?
Yes.
Because maybe there is another reason for breaking window. But sometimes you can see that the window is intact, the glass is intact, and a boy has a stone in his hand, and wants to break the window. After a while, he threw the stone, and the glass is broken based on under your observation. You can say that the stone is the cause of breaking the glass.
Sure.
I see it. Yes? The first example is a cross-sectional study. You cannot say that
The stone.
smoking is a risk factor of hypertension because you do not know the exact time of disease.
Yeah.
Yes? But if you have a follow-up study, a cohort study that we want to review in the next sessions, you see the healthy population and observe them to find who are developing the disease and who are not. Based on that disease, you can say that smoking is a risk factor of disease. So, to say that some exposure is risk factor, you should be certain that exposure happens before disease. Okay? If you do not, you cannot make sure, you cannot say that something is risk factor. You can say that there is a relation between smoking and hypertension. So, be cautious about the interpretation of the result of cross-sectional study. If we want to say something, we should say it is potential risk factor of something, or there is an association between smoking and hypertension. Okay, so if I ask you in the final question, I may provide you an example of cross-sectional study and make you some sentences. You should be cautious to interpret the results of each study correctly. Okay? It is a kind of temporal bias. It is a kind of error. What is temporal bias? Sometimes we do a cross-sectional study, for example, to test a hypothesis regarding the association between physical activity and CHD, chronic heart disease. We think that low physical activity is a risk factor for CHD. But after our study, we see that CHD persons have higher physical activity. How is it possible?
Because maybe the person who has heart disease thinks to himself, I should do more physical activity to improve my health. So he doesn't.
By physician, yes? Sometimes some people have heart disease, so the physician recommends them to do more physical activity. And after that, you select them to come to your study, to participate in your study, and you see that the CHD persons have more physical activity, have higher physical activity. What is the reason? It is related to the previous recommendation of physician. It occurs after disease, not before disease. So it is not a kind of potential risk factor. It is temporal bias. So it is a disadvantage of cross-sectional study. What was the main advantage of cross-sectional study?
To find the prevalence.
Define the prevalence.
Prevalence.
I told you that it is the best design that can
Measure prevalence.
provide prevalence rates for both exposures and diseases. Okay? But the main disadvantage is temporal bias and having no ability to find the exact risk factor. We can just say about association and being a potential risk factor, okay? Not exact risk factor. Okay? On the other hand, we have another limitation for cross-sectional study. What is this limitation? You know that some diseases are more severe. Some cases have more severe disease. So the chance of being alive for that severe disease is lower. Yes? So if you go to the community and select some persons to participate in your study, the severe cases have no chance or less chance to participate in your study. Why? Because they have died before. So, based on cross-sectional study, you can just select the mild diseases, the mild cases of a disease, I mean. So, you cannot say anything about the severity of disease. It is another shortcoming of a cross-sectional study. Okay? Any question? No. Are you tired? No. Very good. But there are the other students.
I think they're tired.
I should check your name again. Asif Amara, present. Muqtada. This is case control study. What do you think about this design based on its name?
We control the environment of the study. So,
Control.
No. Think about case control study. Case control.
Make a schedule for study. Yeah, that we are routine for study.
Could you please summarize cross-sectional study, because we want to compare that design with this new design.
Because cross studying we have both portions. The option. The first one for analytic and the second one prevalence.
No, the second one is the prevalence and association between exposure and outcome.
Yeah, of course. So that relates to take the opinion of the people or take the analytic of the people or student to know who has disease and they don't have a disease. Who's the smoker and who's this another portion of a smoker student, but they don't have disease, and that person has disease. Like this.
Very good. If I ask you that about the situation of participants, do we know who are exposed and who are not?
No.
At the first of the study? No. Do we know who are diseased and who are not?
Maybe we will know.
Maybe.
Yeah, we will.
I told you that we do not know who are diseased and who are not. Because we go to the community and randomly select some individuals. But in this study, we know who are cases and who are controls, who are not cases. The main difference between case control studies and cross-sectional studies is this. In the cross-sectional study, we go to the community and we are blind, we do not know who are diseased and who are not, and we randomly select some individuals, and after that we take their blood pressure to find who are hypertensive or who are not, and ask them about the previous history of smoking. But in case control studies, we go to the hospitals, for example, and select some cases. We know who are diseased. For example, if we want to work on a rare cancer, we cannot go to the community and select, for example, 1,000 individuals. Because if we randomly select individuals, since the disease is so rare, there is no chance to have a case in our random selection. Yes? For example, assume a disease, for example, leukoplakia cancer of the mouth. It is a kind of rare disease. And the prevalence of that disease is 1 per million. And if you want to have 10 cases, you should have
10 million.
100 million. No, sorry, yes. 10 million. Okay? Because I told you 1 per million. Okay? So, is it possible to have a cross-sectional study with 10 million sample size?
No.
No. But it is possible to go to the hospital because we have cancer registry. We have the form of related to the specific types of cancers. We can go to the hospital and use the form and ask and call the patients and ask to participate in our study. And we can select, for example, 50 cases. But it is not possible to do cross-sectional study to find 50 cases. Okay? It is the logic of case control study. So, after we select some cases, we should select some healthy individuals. Why? Because we want to compare these two groups with each other regarding the exposure of interest. For example, if we want to know the association between smoking and leukoplakia cancer, we can select 100 cancer patients, and we can select, for example, 200 controls and ask them about the history of smoking. Okay? So it is the logic of case control. What is the location of case control study? It is a little higher than case control. In this slide, you can see that case control study is among the primary studies, and the level of evidence is higher than case control. Case control is somewhere here, between blue and orange. Okay? Suppose you are a clinician and you have seen a few patients with a certain disease. You observe that many of them have been exposed to a particular agent, biological or chemical. You hypothesize that their exposure is related to their risk of developing this disease. How would you go about confirming or rejecting your hypothesis? Okay, it is a real life example. In 1914, an Australian ophthalmologist observed a number of unusual cataracts among his infants. It was unusual. But after a while, he noted that they had been in the uterus. They passed the pregnancy, the fetus duration during the time of rubella outbreak, and he hypothesized that there is association between contacting with rubella virus and having this unusual type of cataract. After that, they developed a study and found that there is association between these two. Okay? It was the origin of case control study. In case control study, you are here. Have the disease, do not have the disease. It means that at the beginning of the study, you know that who are disease and who are not. And after that, you go backward. You can ask about exposure in both cases and controls. So based on these, you have some disease population, some cases who are exposed, who are not exposed, and some controls who are exposed and who are not. So we have this 2 by 2 table again. Okay? First select cases and controls, then measure past exposure. Cases who were exposed, controls who were exposed, cases who were not exposed, and controls who were not exposed. Who are the cases? A plus C. Who are the controls? B plus D. What is the proportion who were exposed? Proportion of cases who were exposed? A divided by A plus C. And what is the proportion of controls who were exposed? B divided by B plus D. Okay? And if you are able to show the proportion of cases who were exposed is higher than controls who are exposed, it means that there is a direct association between exposure and disease. Okay? Let's see this hypothetical example. How many study samples do we have? 600.
600.
Because we have 200 CHD cases and 400 controls. So the total sample size is 600. Okay? What is the percentage of smoking cigarettes among CHD cases?
Right, 56.
56. 112 divided by 200. What is the smoking rate among controls? 44. It means 76 divided by 400. Okay? The other question. What is the prevalence of smoking among all study population?
56.
56. You can just say the numbers, numerator and denominator.
112
divided by
Huh? No, I do not want the final result, the final number, because I cannot calculate it right now. You just can say what is the numerator and what is the denominator. I asked you about the prevalence of smoking among the study population. Among total population, the study population means total number of population that are who are smoked.
100.
Yes, very good. If we add these two to each other and divide it by our study population, that is 600, it is the prevalence of smoking among our study population. The other question, what is the prevalence of CHD in our study? 200 over 600. Is it true?
Should calculate all of this, isn't it?
It's true.
It's true.
Yes.
It's true. Okay. How many controls do we have per each case?
400. For each?
For each case.
176 for smoking and 200.
Okay, controls per case. 100. I didn't ask you about the smoking. We have 200 cases and 400 controls. It means that per one case, we have two controls. It is clear because the number of controls is doubled. Okay? But you want to, I told you that the beginning of case control study is by our hand. We go to the hospital and select some cases and go to the community, for example, and select some controls. I, as a researcher, decided to select 2 controls per each case. But you, as a researcher, might select 1 control per 1 case because it is in your hand. So we cannot say anything about the prevalence of disease in case control study. Because in this scenario, the prevalence of CHD is 200 divided by 600. But if you select 1 control for 1 case, it would be 200, it would be 200, and the prevalence would be 200 divided by 400. Totally different. The other researcher tried to investigate using 1 case and 3 controls per each case. So it would be 200, it would be 600, so the prevalence would be 200 divided by 800. I told you a difference, an important difference between cross-sectional study and case control study, and I emphasized repeatedly. I told you that in case cross-sectional study, we are able to say the prevalence of disease and prevalence of exposure in cross-sectional study. Why? Because we are blind at the beginning of cross-sectional study for both exposures and diseases. But here, we are not blind for disease. We know who are diseased and we know who are healthy, and we select considering these points. And the selection of cases and controls and the rules, the numbers of cases and controls is by my hand. So it is not possible to provide information about the prevalence of disease in case control study. So if I ask you in the final exam, I may provide an example of case control study, and I ask you which is incorrect, for example, or which sentence is correct. And if I tell anything about the prevalence of disease in case control study, it is incorrect. Because in case control study, we cannot say anything about the prevalence of disease, but the prevalence of smoking exposure, it is possible. Why? Because at the beginning of a study, when we want to select our study population, we do not know who are smoked and who are not. So we can say the proportion of cigarette smoking among, for example, CHD cases, among controls and among our study population. Okay? So we